All right, so my name's Derek Cummings. I'm at Johns Hopkins University in Baltimore, Maryland in the US. It's my pleasure to moderate this session. We've got a really interesting session that is meant to address what the true global burden of dengue is. And so we're going to have speakers who are going to address multiple aspects of the burden: biological, clinical, public health, and I hope we'll have a lively discussion at the end. And so it's my pleasure to introduce our first speaker, Dr. Shirin Kalimuddin from NUS Singapore, Duke-NUS Singapore. So Shirin. Please, the speakers, if you could join me on stage here.
Hey, thanks very much, Adam and Stephen, for inviting me to speak. It's nice to be back here again after 2 years, meeting old friends and making new ones. So in my talk today, I'm going to split it, if you bear with me, into almost two separate parts. The first part is what Adam and Stephen had asked me to speak about for this session. And the second part is, I think we've got some interesting data that's coming out that's unpublished, which I'd like to share with people pretty much for the first time and kind of just get your thoughts on what you think this might be. But both of these topics, I think, converge on the general theme of what we are missing when we think about dengue burden and how we assess dengue burden, both from a disease standpoint as well as from an infection standpoint. Oops, gone backwards. Okay, so this audience doesn't need me to tell you that dengue is increasing. We've got a 30 times increase in dengue incidence in the past 50 years. But how we quantify a burden, another way to quantify burden is actually looking at the dailies or disability adjusted life years. So that's basically life lost prematurely or life that is living with a disability ascribed to dengue. And this, in conjunction with the number of increasing infections incidents in the last 50 years, has been going up as well. So this is data from the global burden of disease. And what we can see compared to 1990, where the dailies was estimated at 1.2 million, we now have almost double the amount, and that's almost 2 million dailies. And this is seen across all age groups, but the burden really is highest in areas like Southeast Asia, so it's not equal among all areas and affects low socioeconomic groups. However, when we think really about what the burden of disease is in terms of dengue, we often focus on what's happening during acute illness, so the time of onset of fever till about a couple of weeks after when patients have all the symptoms of dengue. And this is predominantly how the dailies are assessed. Although now there actually is increasing work that's coming out to suggest that there's actually a burden of illness beyond acute infection, beyond acute dengue. And the global burden of disease does actually include a little bit of this when it calculates their dailies. The problem with this is that the data is actually still quite scarce in this area. There have been very few studies evaluating post-dengue chronic sequelae. A lot of it is mainly focused on fatigue, what people report. Follow-up times have been quite short, so you're looking at a couple of months to 3 months at the most. Often the studies only assess those who actually come back for medical follow-up, so this in itself is a confounding factor because you're probably more likely to come back for follow-up if you are experiencing a symptom. There are retrospective studies, but there are issues with recall bias. And then there's also this question of what sort of control should we be using? Should we be controlling, should our controls be people with just not infected with dengue, or should they be people with another viral illness, for example? So this is a nice review which was done by Bridget Will's team in OCRU, really looking at kind of what the data is when it comes to this looking at post-dengue chronic sequelae. And what you can appreciate on the y-axis is really there's a very wide variability of, this is just reported tiredness and trouble concentrating. And it goes from anywhere as low as 5% all the way up to 80%. You can see that on the x-axis is the duration of follow-up, and really it's quite short for most studies, at most about 2 to 3 months. And a lot of the studies up till now have actually come a lot from Latin America, with very few studies coming from Asia. So a couple of years ago, we wanted to address some of these issues, and so what we did was a prospective study of this is adult dengue patients in Singapore, and we compared them to patients who had an acute respiratory infection. We actually followed them up over a 1-year period, and what we did was we used a mobile phone app to actually collect the data, so we got away with this issue of people coming back, and we found that actually we had a very good compliance rate of close to 90%. And what we found, I mean, it's published already, but the dengue patients, or close to 20% of dengue patients, actually remain symptomatic at 3 months post-infection, and those who were symptomatic actually continued to persist to have infections up to 1 year. And I didn't show this here, but this is actually higher than the patients who had acute respiratory infection, who had about 13 to 14% of them had symptoms. The kind of symptoms that we were getting were things like fatigue, concentration impairment, memory impairment, and what we found is that these self-reported symptoms actually then translated to impairment in functioning. So patients who had chronic sequelae, which we defined as symptoms at 3 months, actually had lower mental component scores on the SF-12. So this is primarily in adults. Again, the team from OCRU, Bridget Wills, has done a study in a Vietnamese cohort, and this is predominantly pediatric patients, so 3/4 of the cohort were pediatric patients, and they kind of call back patients at 3 months to find out what kind of symptoms they had, and close to 50% of these patients actually reported symptoms. And these were, again, quite the usual kind of culprits: tiredness, concentration problems. Interestingly, 12% of patients, actually, dengue patients actually had alopecia at 3 months. Again, this is something that we do see, stress-related alopecia. They had control, so they had 200 dengue patients, and this was controlled to patients with other febrile illnesses, and you can see that the dengue patients generally had higher incidence of these symptoms. Interestingly, I think one of the questions people often ask is does the severity of the acute infection actually translate to more post-chronic sequelae? And here what was found, there was actually no association with acute dengue severity and the relationship of whether you develop post-chronic sequelae. We also found that in our cohort where we compared hospitalized versus non-hospitalized, and there was no difference. Interestingly, the numbers were small, but there seemed to be an association with dengue 3. I think in Eng Yong's talk tomorrow, he'll talk a little bit about why dengue 3 might be a little bit special, but just a bit of a teaser here. So there's a lot of, I mean, there are studies now coming out about kind of self-reported symptoms, although, as I mentioned before, there are issues with many of these studies. But I think one of the questions that really now we want to ask is, beyond these self-reported symptoms, does dengue actually lead to worse long-term health outcomes in terms of hard outcomes like mortality and other diseases, cardiovascular, autoimmune, et cetera, et cetera. So I'm just going to talk about a study done by colleagues in Singapore at the National Center of Infectious Disease and the Lee Kong Chian School of Medicine. This was just published a couple of months ago. And they kind of looked at this Singapore population-based adult cohort. And what they did was they took cases from our National Dengue Registry. So in Singapore, all cases of dengue are notifiable. So this is lab-confirmed dengue, so NS1 positive or PCR positive. And they looked over a 6-year period between 2017 and 2023. So between 2017 to 2020 was mainly dengue 2, and 2020 to 2023 was mainly dengue 3. And they pulled out 55,000 patients who had a first diagnosis of dengue infection, lab-confirmed dengue infection, and they matched it 1 to 60 with 3 million matched uninfected control. So, I mean, we can discuss about whether that's appropriate control, but what they did was then they tried to really kind of correct for any baseline differences in terms of their demographics, their socioeconomic status, their comorbidity index, and whether they've had previous hospitalizations, for example, to weight that and try and make it as balanced as possible. And what they did was then they looked what happened to these people 300 days post-dengue infection. And for the controls, it was basically 300 days from the date of enrollment with where the matched dengue case had their dengue diagnosis. Importantly, they excluded anyone who had a diagnosis of COVID-19 in the 300 days preceding and the 300 days after. And what they found actually was quite striking. You can see from these graphs that the risk of hospitalization, so heart outcomes, hospitalization, death, and MACE is major adverse cardiovascular events, so heart attacks, strokes, and death from cardiovascular disease, was significantly higher in patients who'd had dengue diagnosis in the 300 days preceding compared to controls. They also looked at certain multi-organ sequelae. So these were pre-specified diagnoses. So these patients had never been diagnosed with these diseases before. And what you find is that the patients who had dengue had higher risk of cardiovascular, neurological, autoimmune, endocrine like diabetes, GI, and renal outcomes. Again, we can discuss what is really driving this, whether it really is dengue infection that is triggering this, or are there other factors at play. But this risk was observed across both hospitalized and non-hospitalized dengue cases. It was observed across all age groups, but the risk seemed to be highest in those who were above the age of 60. And it occurred both across the timelines where dengue 2 was predominant as well as when dengue 3 was predominant. And they also looked at kind of healthcare utilization and found that patients with dengue had increased risk of ED visits, inpatient admissions, and the risk of incurring an inpatient cost. So I think if we look at burden beyond acute dengue, I think it's quite clear that patients do get persistent symptoms. There seems to be quite a good, strong suggestion that there's increased mortality and increased healthcare utilization. I think there's, however, still a lot of questions that remain unanswered, and I think this is area for research. So one is severity stratification. How do we stratify these kind of chronic sequelae, beyond death and hospitalization, but like the self-reported outcomes? Are there epidemiological differences? So these studies need to be done across age groups, across countries and regions. And what is really driving these chronic sequelae? My feeling is that it's probably going to be different things for different outcomes. Is it chronic inflammation? Is it autoimmune? And finally, really, what is the impact of vaccination going to be on reducing this beyond just reducing the incidence of dengue? Even if you get a breakthrough infection, like what we've seen with COVID-19 vaccines, can we actually reduce these incidence of chronic sequelae? Okay, in my remaining time, I'm going to completely switch gears now. And we've talked about dengue disease burden, and now I'm going to talk about how do we estimate dengue infection burden? And traditionally, we use antibody responses, right? So we look at serostatus, whether someone is seropositive or seronegative, or whether someone has seroconverted. But I want to put forth the fact, or the question that we really want to answer now is, instead of just using antibody responses, can measurement of cell-mediated immunity, so looking at T-cell responses, actually provide a better estimate when it comes to infection exposure and burden? So why this? So one, we know that antibody titers are going to wane with time. So if someone doesn't have repeated boosting, if forced infection is low, antibody titers are going to wane and they may reach undetectable levels. So again, this terminology of sero-naive may not be quite accurate. You may have had someone who did seroconvert and then antibody titers wane. The other thing we know is that from COVID-19, for example, we actually get detectable SARS-2 T-cell responses in seronegative individuals. This has been shown a few times now. So in healthcare workers, there's this who are followed up over kind of 16 weeks. They find that these people, and they were sampled repeatedly, that they remain PCR negative, seronegative, but actually they subsequently developed T-cell responses against SARS-2. And on the other side, this is a cohort of pediatric cases by Yu Jiazhong, who was a pediatrician and a PhD student in Yong's lab. And she looked at this cohort of children who were either vaccinated or developed natural infection, and she found that there's actually a proportion of children with asymptomatic SARS-2 infection who have no antibody responses, seronegative, but actually have detectable T-cell responses. So the question we want to ask now is, do we find this in dengue? Can we detect dengue-specific T-cell responses in dengue seronegative individuals? So I now turn to a work that's done in collaboration with Bridget. I've shown her picture. She's covering her face. So this is a cohort that was recruited in Okru in Vietnam, and they recruited Vietnamese medical students. So upon entry into medical school, about 50 of them, and they were bled at time points 0, 6 months, and 12 months. And they were measured looking at a dengue IgG, so their stereotatus, using a pan-bioELISA and a T-cell, and looking at their T-cell responses. Just in the interest of time, I'll just briefly talk about this assay that we use. It's a whole blood assay. So instead of PBMCs, it's a whole blood assay that we stimulate with dengue peptides. We then collect the supernatant the next day, and then we measure the amount of cytokine release. In this case, it's actually interferon gamma. This has been done for SARS-2 that was first developed, but we've also done it for yellow fever and JE vaccination, and we've shown that the cytokine release assay actually correlates quite well with the ELISpot assay, traditional assay. So this is the first time point. So this is just on enrollment. And what you can see on the right-hand side, sorry, it's a bit blurred, but on the right-hand side, on the y-axis is actually the T-cell response. On the x-axis is the dengue IgG response, the serostatus of the patients. Anything that is above the horizontal dotted line is a positive T-cell response, and anything that is to the right of the vertical line is a positive serology, so positive dengue IgG. And what you can see is majority of the patients, of the individuals are actually seropositive, and they have a detectable T-cell response. But I think what is really fascinating is that you actually get these about 10 individuals who are seronegative for dengue, but actually still have, interestingly, a detectable T-cell response. And then what you can see is at month 6 now, so the pink dots are the individuals at month 6, and there is, you can see perhaps expansion, a little bit of expansion of the antibody responses. But what you can see is, so the antibody responses are increasing a little bit, but interestingly, in that group that were seronegative, you still see this increase in T-cell response, but they actually remain seronegative. And then at month 3, so now you've got month 3, which is the third time point, which is month 12, and now you can see the antibody responses potentially are starting to contract a little bit, coming back to the left, but the T-cell responses, even in the seronegative, continue to increase up. So this continued upward shift of the dengue-specific T-cell responses over time, even though these individuals remain seronegative. And this is just a sort of different way of showing the data. So on the right-hand side, on the dots that are the empty circles, the white circles, are the individuals who were seronegative at baseline. So you can see that none of them actually they remain seronegative throughout the 12-month follow-up. And then on the right-hand side are the individuals who were seropositive at baseline. And then we looked at their T-cell responses on the y-axis. So overall, what you can appreciate is that in the individuals that were seropositive at baseline, both at month 0 and month 6, they did have higher T-cell responses compared to the seronegative. But what I think is really interesting is that in the seronegative individuals who remain seronegative over the 12-month period, you can see this overall increase in the T-cell response with time, despite the lack of seroconversion. And in fact, by month 12, they reached around the same level as the seropositive individuals. So this was in a Vietnamese cohort, and we've seen this increase in T-cell responses. So we just wanted to see whether we could see this in a separate cohort. So what we did was that we actually had a small little cohort of 9 dengue seronegative individuals. This was Singapore residents. So in Singapore, we have dengue. Dengue is endemic, although the force of infection isn't very high. And possibly a bit of Zika, but we don't have JE, don't have yellow fever, and these were patients with no previous flaviviral vaccination. Here we actually did an interferon gamma ELISpot, so the traditional T-cell assay. And here, instead of using just one peptide pool, we use multiple peptide pools. So dengue NS3, NS5. The NS5 was just dengue 2 because of the size of NS5, but we also had a pan-dengue capsid, pan-dengue envelope, as well as peptides to yellow fever. So we looked at yellow fever, NS3, NS5 capsid and envelope. And interestingly, out of these 9 dengue IgG negative individuals, 5 of them actually had detectable dengue-specific T-cell responses. So you can see here on the, I really don't know what's happened to my the clarity, but I apologize. On the x-axis is the number of spots per million cells, and on the y-axis is the individual subjects. And you can see that 5 of them actually have detectable T-cell responses, but the pools that they're responding to are a little bit different. So not everybody responds to the same pool. So for example, For subject 13, they have a response to capsid, a very strong response to dengue capsid, a slightly weaker response to dengue NS3, NS1, but still present. And in SJ15, the first subject, there's really only a response to dengue NS3. And interestingly, none of the individuals actually had any response to yellow fever stimulation with yellow fever peptides, which is what you would expect in somebody who's not been vaccinated with yellow fever. We also thought it was quite interesting that out of the 5 individuals who had dengue-specific T-cell responses, 4 of them actually all had responses to capsid, and capsid is actually quite a small protein compared to the others. And we've shown before in a yellow fever and JE vaccination challenge study that actually in the absence of neutralizing antibodies, it's actually the capsid-specific T-cell response that seems to be associated with viral control. So the higher your capsid-specific T-cell response, the better your viral control is. So, whether this has any relevance to why these people manage to control infection without seroconverting. So in conclusion, since I have 11 seconds left, so one is potentially, I think what we're suggesting here is that serology may actually underestimate the true burden of dengue, and perhaps we should use seropositivity, which I credit to Adam as the term, as a more sensitive indicator, or even at least a combination of the both. We need to do this. We need simple, scalable, and cheap T-cell assays, because in the past, doing PBMCs and flow cytometry, ELISpot is just not feasible in the large amounts. So potentially this whole blood assay is something that we can use. We're now in a collaboration with Adam and Henrik to try and push this out. And finally, I think there's still a lot of questions that we need to ask. What is the cross-reactivity going to be with other orthoflaviviruses? And can we actually differentiate between the 4 different dengue viruses using T-cell responses and cell-mediated immunity? And this is also something that we are looking at. So I'm going to stop here and thank you. So many people to thank and part of this work. So the WE Lab, Bertoletti Lab at Duke-NUS, my colleagues at the SGH Department of Infectious Diseases, Viremix led by Eugenia, who's here. Of course, WE Lab in Yong, everybody knows. And then Prof. Bridget Wills from OCRU in Vietnam, who ran the medical student study. So I'll stop here and thank you.